Hey everyone, this is Andy DeLeo, better known as Cancergeek. It is Monday, April 25th, 2016, and this is the patient scene. On tonight's episode, we were supposed to have a guest, Kristen Coppins, better known as Chronically Kristen. However, Kristen is not able to join us this evening because she's actually not feeling that well. And my counterpart and my co-host, AJ Montpettit, is also unavailable this evening. So it's going to be me this evening kind of talking about patient experience, patient care, and some topics that I've seen over the course of the last week in my travels. And in the event that anyone is out there and decides that they want to join, please feel free to join the blab, or feel free to send me a message or notification via social media or any questions, and I will take them as they come in as well. So with that being said, one of the things that I was reading recently, and actually talking to one of my counterparts, happened to be about patient care. And specifically about patient care, it's really about the time. So the time that it takes from thinking, oh my goodness, I think I may have something, to actually finding out what it is that you have. And then from that point, transitioning into going from knowing that there's something wrong with you and understanding what the treatment recommendations and options are. And so Sherry recently shared a bunch of slides that kind of talked about this specific to breast cancer. And from my perspective, I thought it was interesting because this is where I've spent a majority of my work and my focus on during my career, is really sort of looking at these transitions in care and understanding what it is that's important to patients along those journeys and whatnot. Hey, Steph, how are you? So with that being said, one of the things that I did is we noticed that in the US specifically, that the time that patients go from thinking that, hey, I think there's something wrong with me, to actually knowing what their treatment recommendations or options are for cancer, on average is about 10 days. Now, that average slightly varies based on if you have early stage breast cancer or later stage pancreatic or lung cancer. It also differs based on if you had a community hospital or an academic medical center. But on average, for all comers, it's about 10 days. And what we also noticed is that when you start to look at other types of diagnosis, such as lung cancer, it can be as high as 60 to 90 days, which is kind of frightening when you think about the median survival for some lung cancers as only being about 12 to 18 months. So that could potentially be a third of a person's sort of survival, just sort of waiting to understand, hey, what's wrong with me and what can I potentially do about this? And what we decided to do is to change the game and to understand that a little bit more in depth. And the way that we did that is that we actually did a bunch of ethnographic research. And so we went into the community and we really understood the various segments of patients. And as we understood those segments of patients, we realized what were the different ways that they were entering into the healthcare system. So some were entering through the emergency room, some were entering through their primary care physicians, others were coming in for routine screening, whether it's colonoscopy, mammograms, some were coming through their ENTs. There were multiple ways in which patients were entering into the system. And as we started to dig a little bit deeper and understand what was the various ways in which patients were entering the system, we started to realize what some of those barriers and challenges were. Some of them had to do with just being able to get to a facility or a clinic. Some of it was about identifying who is the right care provider that people should be scheduling with. Some of it was as simple as just what were the hours, because people have work and children and extracurricular activities. There were some barriers based on just scheduling and time. And so as we collected all of that research and we spent time understanding the various challenges, then that's kind of when we were able to adopt the right technologies and the right ways to sort of bring about the clinical workflow. And so what we noticed is that it was all about getting the right information to our pathologists and our radiologists at the appropriate time so that they could make a decision appropriately and then expedite the rest of that information to the rest of the care team. And so what I mean by that is that when a radiologist is reading an imaging scan, a lot of times they need additional information. They need information that's coming from a referring physician. Maybe it's outside films. Maybe it's some lab work. Maybe it's previous history. There's a lot of information that radiologists need that help them sort of put all the pieces together and understand what it is that they're looking at to make a definitive diagnosis versus saying, you know, hey, further workup needs to be done for X, Y, or Z. And so what we created was a process in which we could get that information to the radiologists as quickly as possible so that when they were ready to read the scan and the image, that all of the information was just there. They didn't have to look for it. They didn't have to call for it. They didn't have to search for it. They didn't have to collect it themselves. It was just there. And likewise, we did the same thing for pathologists. And with pathology and sort of understanding at a cellular level what's going on, some of that just naturally takes about 3 days because you've got stains and you have slicing and you have to prep the slides and there's a lot of different things that go on with that. And so what we did is we kind of brought the teams together and realized what were the information gaps that they had, and we figured out how to create a process in order to sort of fill those gaps. And at the same time, we also realized what our time-limiting steps were. So, for example, pathology, there's some things that just cannot get done faster than 3 days. But it was great because by understanding that, we could then begin to also figure out how we were going to communicate back to patients and let patients know sort of what was going on with their workup, what's going on with understanding what the right answer is, and then making sure that there was someone assigned to each of the patients in order to deliver that timely information. And that if patients or their family members had any additional questions, that they had one person that they could call and talk to all along their journey. And so it was this wonderful process that we were able to put together. And in doing so, what we were able to do is beat the national average of 10 days and actually accelerate that into 72 hours or less. Now, the caveat to that was that it was all based on the patient's preference. We knew some patients wanted to go very quickly, and we knew other patients, either based on their geography and their support systems, maybe based on work, maybe based on children, maybe based on other things, that they didn't want to go quite as fast. And so what we did is we developed a process in which it gave the patients the power to choose. If you wanted to go fast, we could. If you needed to go slightly slower, we could do that. But you've got choices and you've got options. And all along the way, if you want to change your mind in that choice, you had the ability to do so because you had one point of contact that was basically your navigator or your coach through this journey. And so it was something that was wonderful, that patients truly were receptive of. And we were able to sort of bring this to other parts of the healthcare organization beyond just cancer, which really sort of, created this timeliness thing. But beyond just the timeliness, it was the trust to know that whatever choice a patient wanted to make, it was their choice, and that all of the information would be collected and shared with them in a very transparent way. So it was able to build this great trust and this partnership between patients and clinicians and the healthcare system and the people that we serve in our community. And so from my perspective, when I talk about an ideal patient experience and patient experience in general, that's really what it's about. It's about the power of choice. It's about the power of understanding the people that we serve in that community and giving them the options that they want at the time that they want them and in the manner in which they're seeking them. So that's a little bit about kind of, patient experience and sort of my take on it with processes. I would say another thing that I happened to see recently was shared actually this morning in regards to So I'm just reading a couple of things here from the live chat. So Care Radio just said, being upfront and transparent helps the patient to have some control over something they have no control over. I completely agree with you. Exactly. I think based on the research and the time that I've spent with patients, whether it's myself being a patient or family members or the people that I've cared for, that it is. There's this anxiety, there's this transition of going from, hey, I'm healthy and I'm feeling good, to I think there's something wrong with me and I want to know what that is. And there is a sense of loss of control. And so being able to provide that information and those options and those choices is empowering. It gives some of that control back to the patient. So yes, I completely agree with you. I think that's imperative for people and for patients to have. As I was mentioning, there was an article earlier today that I read that was talking about the deployment of drones in some of the developing nations. And what that was able to do was to actually collect lab samples, blood samples, and take them back to a remote lab and run the blood work, and then be able to deliver those lab results back to patients that happen to live in rural areas, whether that happened to be around malaria, HIV, or other types of things. And that, for me, was really exciting to read and to see and to understand, because so many times when I open up, a magazine or the paper, or I read, feeds on Twitter or in my email, is that it's technology just to talk about technology. So yeah, it's great because there's a new app, or yes, it's great because there's telehealth and telemedicine. But it's not necessarily always talked about how that technology solves a specific need that people in a community or a population have. And for me, this was super exciting because what it represented is that someone took the time to actually go and meet and understand and listen to the people in some of these rural settings and to understand what some of the challenges were, and then pick the right technology that allows that to happen. And when we talk about empathy, when we talk about design thinking, when we talk about ethnography, that's really what we're talking about. Is we're talking about taking the time to roll up our sleeves, to immerse ourselves in a population, and to really sort of sit and listen and understand to the challenges that are going on that people living in that population have. And the more that we do that, and the more time that we spend doing the work like that, the easier it becomes in understanding what is the right technology to deploy that enables the processes and the people to develop and create the choices for patients to have in order to have an ideal patient experience. And yes, as Stephanie so eloquently said, so simply because we have or can doesn't mean we should if it doesn't offer real solutions. And that's so true. I think that's where a lot of the cost and some of the waste in healthcare resides in, is because we're looking at the next, widget, the next gadget that can, kind of be plugged into something and it's going to magically fix it. And from my perspective, we need to spend more time in actually rolling up our sleeves, spending some time listening, and actually defining what the problem is from the people in that population's perspective. And there's hundreds of millions of solutions out there between technology and process, and then the people to deploy that. But in order to do it effectively and in a way that actually impacts people, we need to spend the time doing the research, to spend the time in actually having empathy, and spending the time in actually listening to those people in that area. And then it becomes developing those choices so that the people that are living in that experience, in that everyday life, then have the power to choose. And to me, that's what patient experience is. That's what it's supposed to be about. It's supposed to be about empowering each person to have the ability to choose whatever their version is of an ideal patient experience. So since I am flying solo this evening, I'm sure, not many more people want to hear or see me pontificate for much longer. So it's been a great evening to sort of share some of my thoughts, some of the stuff that I've seen this week. And I will be more than happy to join everyone again next week when AJ will be back. And I'm hoping that Kristen will be feeling better as well, so that she'll be able to join us. And I'm also working on a special guest as well. So Sumit Patel, I'm hoping will be able to join us next week as well. And he's a young, up-and-coming, energetic physician. So crossing our fingers that everyone's feeling good and well, and we'll be here next week. So next Monday on the patient scene. Until then, I wish everyone a great rest of their Monday evening, a great week. And if you have any other questions, thoughts, or considerations, feel free to ping me on Twitter at Cancergeek or send me an email at cancergeek@gmail.com. Thank you.